Hello, thank you for viewing this provider training for the Reverse the Cycle program that is being implemented in the emergency department at Beckley Appalachian Regional Healthcare. Today, I will review with you the Reverse the Cycle model and how it is being implemented at Beckley ARH, and help you understand the role of the provider and one of the components of the model, which is our medication-assisted administration in the emergency department. To give a little background about why we are here, the Reverse the Cycle model is a comprehensive substance use response model that is designed to work in an emergency department and has been implemented in over 50 hospitals across the nation, including Hazard ARH and Whitesburg ARH hospitals in Kentucky. As we look at substance use, we recognize that it is a national public health crisis. To understand the importance of having a model like Reverse the Cycle in your emergency department, I will provide some context and share data on substance use nationally and locally in West Virginia. In 2017, there were 20 million people who needed substance use treatment based on their risky behavior, whether that was alcohol use, prescription misuse, or other illicit substance use. However, only 1 in 8 of those Americans were receiving treatment. And those other 7 individuals, for any number of reasons, including barriers such as childcare, transportation, and health insurance, could be reasons they did not attend treatment. But what we find even more so is that many of those patients did not think they needed treatment. In that same year, there was over 30 million Americans who had tried an illicit substance in that month. And since 2015, drug overdose has been the #1 cause of injury-related deaths in the United States. As we shift now to looking at opioid-related emergency department visits, the research indicates that each year we have seen 20 million individuals visiting the emergency department for an illness or injury, and between 15 to 20% of those individuals were identified as having a substance use disorder. And for trauma-related visits, this statistic increases from 25% to 50%. This graphic shows us that opioid-related emergency department visits have been on the incline since 2010. Taking a look at West Virginia more closely, opioid-related inpatient stays fell in the highest range nationally. In 2015, West Virginia had a rate of more than 350 opioid-related inpatient stays per 100,000 population. When it comes to drug overdose deaths, according to the CDC, there were over 60,000 drug overdose deaths reported in the United States in 2018. Over 46,000 of those deaths were attributed to opioid overdoses, which is nearly 70%. West Virginia is the highest among the states for opioid overdose deaths. The state had a rate of 51 deaths per 100,000 population in 2018. You can see here in this graph, we are showing the increase in overdose fatalities from 1999 to 2018. Taking a look at the blue line first, in the early 2000s, West Virginia saw prescription opioid overdose deaths begin to climb, with periods of decline and incline over the next 18 years. The yellow line is synthetic opioid overdoses, which were relatively low from the early 2000s until 2017, when they began to peak incredibly high, which has a lot to do with the introduction of illicit fentanyl, which has a very high potency. We see synthetic opioids topping out the group of drugs listed here and contributing to 702 deaths. Lastly, with the orange line, which is heroin, we see this drug did not really begin to contribute to a higher level of overdose deaths until 2013. And in 2018, we saw it contribute to nearly 200 deaths. So as I mentioned, the Reverse the Cycle model is a comprehensive substance use response program. Beckley ARH has received funding from the Mosaic Group through an award from the CDC to implement the Reverse the Cycle program in your hospital. There are three components of this program, which begins first with universal screening and then a peer intervention. The Overdose Survivor Outreach Program, known as OSAP, and then there is the medication-assisted treatment initiation in the emergency department. Now I will walk you through how the Reverse the Cycle program will be integrated into your existing workflow in the emergency department. The Reverse the Cycle protocol that has been approved at a system level by leadership at Beckley ARH includes having all emergency department patients ages 18 and older being screened by their nurse during nursing assessment. The screening tools are located in Meditech and include a series of questions used to determine a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug misuse. If a patient scores a 7 or greater on the audit C, which is the tool to determine risky alcohol use, and or answers yes to either of the two drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. There are also what we call exclusion criteria that result in a positive screen, which I will share with you on the next slide. Here you see a screenshot of the screening tool used by nursing, which begins with the exclusion criteria. Some criteria, if met, will not lead the patient to participate in the screening. There are other criteria, if met, that will lead the patient to be considered a positive screen. For example, if a patient is under the age of 18, nonverbal, or critically ill, they will not participate in the screening. But then there is the criteria of being identified as an opioid overdose, non-opioid overdose, intoxication, or provider requests, which will lead a patient to screen positive, but does not require nursing to ask the questions below pertaining to a patient's alcohol or drug use. The idea behind this is that if a patient meets either of those criteria, the likelihood of them effectively responding to those questions is impacted. Therefore, their identification alone by nursing meeting either of those criteria will lead them to screen positive. If the patient does not meet any of the exclusion criteria, then the nurse will proceed with asking the 3 audit C questions and 2 drug use questions you see below the exclusion criteria. If a patient screens positive, they will have a peer recovery coach come into the room to speak with them about their substance use. The foundation of this program and the individuals who will be working with substance using patients in your emergency department are called peer recovery coaches. Peer recovery coaches are individuals in long-term recovery from substance use disorders that are trained in motivational interviewing and other skills to use their lived experience to help patients that are in active addiction. These individuals will have a conversation with the patient who screens positive for risky alcohol or drug use and make referrals to treatment as appropriate. There will be 3 peer recovery coaches based in the emergency department and 1 peer recovery coach who will work in the community, specifically with patients who have come to the emergency department as a result of an opioid overdose. The community-based peer recovery coach is the one who works within the second component of the program that I mentioned a bit earlier, called the Overdose Survivors Outreach Program. This individual will provide intensive outreach and follow-up with patients who have presented to the emergency department following an opioid overdose. The visual here shows an overview of the peer recovery coach's workflow. It begins with all emergency department patients ages 18 and older completing a universal substance use screening with the nurse. If the patient screens positive for risky substance use, the peer recovery coach will receive an alert on their track board in the EMR that a patient with risky substance use will need to be seen. The peer recovery coach will review the patient's results on the screening, review their medical history, and the reason for the patient being in the emergency department. The peer recovery coach will then meet with the patient to have a conversation about the patient's substance use. Based on the conversation the peer recovery coach has with the patient, in collaboration, they will make a plan to address the patient's substance use. This plan could be anything from a referral to treatment or a plan to reduce use. Once the peer has spoken with the patient, if they have reported any opioid use, we want to consider them for a dose of buprenorphine in the emergency department if they are motivated to go to treatment. Mosaic has implemented this component of the program in hospitals across the nation, as I mentioned, since 2014. And it has been about 4 years since we have been working with hospitals to provide a dose of buprenorphine to patients who are opioid using in the emergency department. There is a great deal of research and science that supports medication-assisted treatment of opioid use disorders, that it does save lives. I will now share with you some of that research. To begin, a consensus study report in 2019 by the National Academies of Sciences supports that buprenorphine does save lives. We also know that the risk of opioid overdose death declines immediately when the patient has an opioid use disorder and are initiated with buprenorphine treatment. Medication-assisted treatment has been found to reduce mortality by up to 50%. Both methadone and buprenorphine have been linked to substantially decrease the risk of all-cause deaths and overdose-related deaths. Both medications reduce the number of opioid overdose deaths in the community. And with expanding access to these medications, we see a reduction in the number of deaths due to opioid overdose. Buprenorphine is also associated with lower rates of other opioid use, improved social functioning, decreased injection drug use, reduced HIV transmission risk behaviors, reduced risk of HIV diagnosis, reduced risk of hepatitis C infection, and overall better quality of life. You may be familiar with the D'Onofrio study out of Yale, where they similarly, out of an emergency department, had 3 study groups. One was initiated with buprenorphine and a 3-day prescription with a referral to a primary care provider with continued maintenance therapy. One group received a brief intervention and then got a referral to treatment with no medication. And the third group received a simple referral to treatment. And what you can see in terms of engagement in treatment at 30 days was that their retention and any self-reported illicit opioid use, as well as their toxicology report for opioid use, the group who received buprenorphine in the emergency department with that coordinated link and bridge to care did better across all 3 components. They were retained in treatment at a rate of 78%, much higher than the other 2 groups. Their self-reported illicit opioid use was fewer days, and their urine toxicology negative was at a higher rate than the other 2 groups as well. When we think about practitioners using narcotics to treat opioid addiction, there is a separate registration or waiver needed. The Drug Enforcement Administration has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not a waiver provider to administer but not prescribe narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under this exception, ED physicians are permitted to administer buprenorphine to patients for no more than 72 hours. So when we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they are in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, allowing them to participate more actively in their healthcare. When patients feel better, which happens almost immediately after receiving the dose, they can understand their discharge instructions better. They are less likely to leave AMA out of a fear of getting sicker. And when they feel better, they are less likely to use an illicit substance overnight before they go to treatment the following day. We also know when patients receive a dose and avoid illicit use, they're more likely to engage in treatment within 24 hours. And when we look at our data across hospitals, we know that the patients who received a dose of buprenorphine in the emergency department show up at a rate of 65 to 70% higher, so that there is a very high likelihood that they're going to enter treatment the following day. So the way that this component works is the patient has already screened positive and has received a brief intervention from the peer recovery coach. Through that conversation, the peer has determined that the patient is motivated for treatment and is willing to go to care the next day. Those are really the two components that the peer is figuring out, that the patient wants to go to treatment and they are willing to go the following day. At that point, the peer recovery coach is going to talk to the provider to let them know the patient is motivated, opioid using, and should be considered for a dose of buprenorphine in the emergency department. The provider is then going to assess the patient for any exclusion criteria, which I will review with you as part of the ARH protocol. And then they will order the clinical opiate withdrawal scale. The nurse is going to conduct the clinical opiate withdrawal scale, which does exist in Meditech. If the patient has a score of 8 or greater on the clinical opiate withdrawal scale, then the provider will order an 8 milligram dose of buprenorphine. The nurse will then administer and observe the patient is taking the medication. And meanwhile, the peer recovery coach is working to coordinate the patient's care for the following day. And I will go into this in more detail, but those are what we call our fast track providers. These are providers in the community who we have developed protocols with so that the peers can refer patients to them either the same day or next day for continued induction and maintenance. When a peer has recommended the patient be considered for a dose of buprenorphine, there are some exclusionary and cautionary criteria the provider should consider. So we do not want any patients to be on any long-acting opioids for pain. If there is any evidence of liver disease, or if the patient is in any acute psychiatric distress and unable to consent to treatment, then we would not want to consider them. Or if the patient reports any allergy to buprenorphine or naloxone. We also want providers to proceed with caution, but not exclude the patient entirely if there is any prescribed or illicit benzodiazepine use, or if the patient is pregnant. Neither of these disqualifies the patient, but we do want to make sure you feel comfortable dosing the patient and proceeding from there. Here I have included the MAT order set. When the peer notifies the provider that a patient should be considered for a dose, there is also a trigger that notifies you as the provider that it is time to consider the patient for any exclusion or cautionary criteria. And there is a MAT order set that you will be able to follow in Meditech. You will see here on this screenshot, it includes the exclusion and cautionary criteria at the top. It also includes nursing orders for the clinical opiate withdrawal scale, the medication, which is mentioned is an 8 milligram dose of buprenorphine, and the consult for the peer recovery coach. As part of the MAT initiation protocol, it is also important to make sure that the patient meets the DSM-5 criteria for a substance use disorder, which is outlined here. As I mentioned, the nursing team will be doing the clinical opiate withdrawal scale. This is a series of 11 questions that the patient can score on, and any score of 8 or higher makes the patient eligible to receive a dose of buprenorphine. Displayed here is a screenshot of the clinical opiate withdrawal scale. In terms of how buprenorphine works, as you know, there is a ceiling effect, so the patient cannot get high. There is also the naloxone present that blocks the opiate effect if injected. The visual here simply gives us a picture of the empty receptor and shows how perfectly the opioid fits into the receptor. However, with the presence of buprenorphine, if there is any opioid that enters the person's system, the buprenorphine makes the receptor an imperfect fit for the opioid to nestle into the receptor. We are giving patients an 8 milligram dose of buprenorphine, and we have not seen a high rate of precipitated withdrawal occur. But we do know withdrawal is more likely to occur when there is a level of physical dependence that is high, or there has been a short time since the patient's last opioid use. or if that initial dose of buprenorphine is too high. So again, that is why we do the clinical opiate withdrawal scale, to make sure they are far enough into withdrawal that we might prevent precipitated withdrawal, and we look at the exclusionary and cautionary criteria. If the patient happens to go into precipitated withdrawal after you've administered or the nurse has administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition to that in order to try and prevent or end their precipitated withdrawal. While the provider and nurse are working on administering the patient's buprenorphine, the peer recovery coach is arranging for the patient to be referred to a fast track provider. Fast track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from Beckley's emergency department who has been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast track provider has a unique protocol the peers will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there is likely an appointment available the following day. The Reverse the Cycle program will be going live at Beckley ARH on August 25th. The peers will be in training with the Mosaic group the week before Go Live Day. Tiffany Latham, who is a senior behavioral health consultant with the Mosaic group, is a primary consultant working with Beckley ARH to support this program. She will be providing in-person and remote technical assistance to support the peers and any other clinical staff throughout this process. Her phone number and email address are listed here. She will be checking in with the peer recovery coaches almost daily and working with the planning team to continue with the support of implementation. Thank you so much for your time, and please reach out to Tiffany with any questions you may have. Have a great day.